Thank you, everyone. I want to thank you for the opportunity to be here today. And I know it's getting late in the day, so I'm going to do the best I can to add some value to your time. I guess we need to make the disclosure. I have no commercial interests here. And I just came up with this idea of describing the ligament abnormalities and how they may affect spinal alignment and how it may lead to neurological impairment. So what I mean by this is if we take a look at the picture on the left, basically this x-ray is called a nasium or a frontal x-ray. And this red line here, which is high on the left and low on the right according to the marker, that is a line through the C1 vertebra, the atlas. So this shows a misalignment of the atlas. And consequently, this was a first x-ray I took of a patient who was being monitored for multiple sclerosis. And these are lesions or plaques that are seen on the MRI. So I wanted to just share something I learned a long time ago. It was a saying about the central nervous system, and that is that the purpose of the central nervous system is to control and coordinate the functions of the body and to adapt the body to its environment. So as we look at some of these images today, I just want to keep coming back to the idea that the nervous system, its purpose is to control the functions of the body. So if we start to look at impairment, we may be looking at not the proper function that we should have. So we end up at the starting point looking at abnormal spinal alignment, that it may be due to trauma. And that's been brought up earlier by some of the other speakers talking about concussions and so forth. And it may be due to repetitive strain, problems in posture, people in work environments that have physical stress on their body. And as a result of the spine being out of alignment, it can develop into abnormal posture. And we had some great discussion earlier today about abnormal posture. And it can be associated with ligament abnormalities as well. So I'd like to think that on a continuum, there may be a precipitating event that leads to persisting misalignment. And for normal ligaments, that threshold may be described as a trauma resulting in injury, but maybe for other people with ligament abnormalities, it may not take quite as much force or quite as much energy to cause a similar kind of problem. But ultimately, as a result, it can lead to a failure of ligaments to constrain the normal movement. We're going to be looking a little bit at movement today with some of the imaging. And as a result, this can put direct mechanical stress on the central nervous system, and it may impair brain and central nervous system function. So I want to just look at the neck and what we call the craniocervical junction. So this is the area where the head connects to the neck. And you know, we can see how somebody can get themselves into trouble if they get hit like that, or like that, or like that. But it could be a car accident, it could be a fall, it could be something relatively innocuous. But the point is that if there's a problem at this area, then it can have an effect on the nervous system. And this is why what we call advanced imaging is so important. It's not enough to really just have an x-ray that says there's a loss of the normally occurring curve in the neck or something like that. Now, this is a video. On the left, we have what's called a digital motion x-ray, also known as video fluoroscopy. And this is a flexion extension loop. It sort of glitches a bit, but you'll see it goes into full flexion, and then it goes back into full extension. So we can look at the movement here, and we can see a few different things. So if I just let it go over into flexion, and we just, yeah, okay. Try that again. See if I can just get this to stop for me. Right there will be good. And what we see is a forward excursion or translation of, this is the C3 vertebra on C4, which means that the posterior longitudinal ligament, which normally stabilizes the spine when it's moving in this direction, is failing to constrain the movement. And so consequently, the weight of the head is pulling, sorry. Wait, I'll try that again. Okay. The weight of the head is pulling the vertebra forward, and it's creating a mechanical stress on the disc, but it's also doing quite a bit more than that. And I want to just, I seem to be getting tricked here a little bit by the mouse configuration. I want to show a couple more things here, and then we're going to talk about the video on the right. So if we look up here at the top, we see this is the odontoid process of C2. And as the head goes forward, it approximates, and as the head goes back, it widens. And that means that the apical ligament and the tectorial membrane are failing to constrain the movement of the weight of the head as the head bends backward. And consequently, it's putting direct mechanical stress on the spinal cord. We can also see, as the head goes forward, I'm just going to try this one more time. It's a little hard to see, but there's a little white line there, and it's a little crunchy looking on this picture. But that's an increase in what's called the atlantodontal interspace, meaning that the transverse ligament, which normally stabilizes this area, is not constraining the movement. And again, the weight of the head is causing the atlas to slide forward. That means that the spinal canal is being made smaller between the back of C2 and the posterior arch of C1. Now I'm going to turn our attention over here to the cine. This is the same patient. This is an upright MRI, what's called a cine loop. So this is a series of images that were sewn together to make this video clip. And what we can see is as the head bends back and forth, we can see disc bulging here that's pressing down into the cord. We can also see the cerebellar tonsils moving up and down as the head goes back and forth, showing us how the tension on the cord, it seems to advance that. There we go. As the head goes forward, it's pulling the cerebellar tonsils down. So we can see that through these simple everyday movements, the spinal cord is literally being traumatized because the ligaments are failing to constrain the motion of the vertebrae. And while the vertebrae should really be acting like a suit of armor around the central nervous system, in this case, they're actually insulting the nervous system. So we can start with a simple X-ray, a side view of the neck, and we can look for certain radiographic features that will tell us that there's a problem. For example, we look at the interspinous spanning, or fanning, I should say, or the distance between the spinous processes. And this gap here suggests that a ligament going along here called the interspinous ligament may be suffering from disruption. We can look at a problem with the joint surfaces not being parallel, which suggests that the capsular ligaments may be failing to constrain the movement of the vertebra. Then we can see a translation like we saw on the DMX, where the vertebra is sliding forward off of the one below, which is putting hard mechanical stress on the disc, and it's also putting stress on the nervous system itself, because you can imagine if the spinal cord is going along down through the spinal canal, that this abrupt change in direction would be putting stress on it. So if we see any of these features, including angulation, which is easily measured, this would suggest right away that we should explore this further to see what happens when we stress this spine. So that would be suggesting that we should take a flexion X-ray, the head bent forward, and an extension X-ray with the head bent back, so we could see the two end ranges like we were seeing on the DMX. Craniocervical syndrome symptomatology and its origin in prior trauma to the neck. And we're talking about a study that looked at records of presentations of people, and the most common thing that was seen was pressure headaches. So these are severe headaches that most frequently described by the patient as severe pressure headaches or migraines. Headaches described as suboccipital neck pain in the back of the neck and at the base of the skull. Neck pain that is frequently position dependent. For example, when the head goes forward or the head goes backward or the head turns. Neck pain described as a knife stabbing or pins and needles stabbing at the base of the skull. Headaches occurring randomly throughout the day, but frequently generated by a change of head position. For example, moving the head from recumbent to upright, and that was described a little bit earlier too. Headaches accompanied by ringing in the ears, visual disturbance, blurred vision, and other things of that nature. And oftentimes these pressure headaches can be accompanied by dementia and loss of cognitive skills. Additional symptoms that can be encountered include drop attacks, dizziness, loss of balance, numbness of the legs, difficulty walking, paroxysmal vertigo, sudden dropping of things from the hands, loss of color vision, loss of motor skills in the lower extremities and potential wheelchair confinement, numbness and tingling in the legs and feet, vertigo on standing and walking, numbness and loss of motor control in the upper extremities. Now we're going to talk about cerebellar tonsillar ectopia and whiplash trauma. It's a case-controlled study of cerebellar tonsillar ectopia, Chiari, and head neck trauma, whiplash, and the authors Freeman, Rosa, et al. This data represents the first large series of patients scanned in both upright and recumbent MRI scanners with the intention of evaluating tonsillar ectopia. Whether or not tonsillar ectopia results from whiplash trauma, the condition is approximately 4 times more prevalent in whiplash-injured neck pain patients than neck pain patients with no recent history of trauma. So here's a proportion of cases in the non-trauma group. They could see abnormalities at the foramen magnum 29% of the time in the recumbent population, 30% of the time in the upright population. But in the trauma group, when they're lying down, it was 41.7%. But when they went upright in the effects of gravity, the number increased to 76%. So in the study of 1,200 patients, tonsillar ectopia was identified in 1 in 4 trauma patients versus 1 in 18 non-trauma patients. Upright position MRI imaging appears to increase the sensitivity of MRI to tonsillar ectopia by more than double. The utility of this modality deserves further study and wider acceptance. And I know I say this in a town that doesn't have an upright MRI scanner, and I'm not saying it to be provocative. This is just the conclusion from this study. I think there's one in British Columbia. Here's a little, sorry? Oh, okay, no, okay. So this is a little paper called Facts on the Go, Facts for Docs on the Go, Chiari 1, and it was endorsed by the Chiari Institute. The cerebellar tonsils herniate into the foramen magnum and may occupy a small portion of the upper cervical spinal canal. They're visible on mid-sagittal and slightly parasagittal MRIs. However, in some cases, the tonsils wrap around the brainstem or curl up like tiny snails. Then their appearance is more subtle, but their effect is just as debilitating. The reason for symptom and sign manifestation, and an important key to the severity of the case, is the deformity's effect on cerebral spinal fluid dynamics. I got a typo there. The cerebral spinal fluid, I got it twice, great. Cerebral spinal fluid flow is turbulent, reduced, or absent in 1 or more locations. The adjacent brain tissue receives little nutritional support, cellular byproduct removal, or cushioning from the effects of mechanical or Valsalva maneuvers. Signs and symptoms can number in the dozens and can appear to exist in unrelated symptoms and can wax and wane as influential factors change. Take good care of these patients. Typically, they suffer for a long time with no name for their assailant. Explain Chiari to the patients and reassure them that they're not psychologically ill, that their compressed brain tissue and altered fluid dynamics do have measurable effects on their physical function. Now, it just said a moment ago that sagittal imaging could be used to identify this Chiari or cerebellar tonsillar ectopia, but I'm here to say that's been kind of proven untrue in some examples since 2005. Here's an example of a sagittal MRI, and I think most viewers would say it looks pretty good. The cerebellar tonsils are up above the foramen magnum. In fact, if you take a look at the mid-sagittal slices on this patient going right through, the cerebellar tonsils appear to be fine on every image. But when we take a look at the coronal view, we can see that the cerebellar tonsils are below the foramen magnum and they're filling up the spinal canal. Same thing can be said on the axial view. The cerebellar tonsils are down here and they're blocking the flow of cerebral spinal fluid from out of the cranium. So we can find abnormal cerebellar tonsils on the axial view. We can see them on the sagittal, and the T1 sequence is generally preferable because of the nice contrast that you get between the cerebellar tissue and the CSF, so it's easier to see the border of the cerebellum. And it's, again, very easy to see on the coronal view. You can also pick it up on CT scans sometimes, and here's an example. This is a paper from 1978. Oppenheimer did some dissections of spinal cords of patients who'd had multiple sclerosis. And one of the notes that was made there was that the plaques in the cervical spine could be related to the lines of attachment of the denticulate ligaments. The denticulate or the dentate ligaments attach the spinal cord on the inside of each vertebra. And their purpose is to keep the spinal cord sort of in a safe space as the head is bending and turning. But if the spine gets twisted, if the spine gets knocked out of alignment, it takes the spinal cord with it, and consequently it creates an axial tension or stretching of the cord. And what this shows is that the denticulate ligament was pulling on the tissue, and as a result, it was affecting the perfusion of fluid. So it appears as though the plaques that are seen in multiple sclerosis are like almost a drying out of the cord. There's an improper physiology going on in these areas where they're under tension. And when it comes to Chiari patients, the most common presentation is cognitive impairment, followed by numbness and tingling, throat and GI issues. And headaches comes in a sorry fourth, considering that Chiari is actually involving the brain. But anyway, the point I make here is that this is an indication of a wide range of different problems that people can have, and they all trace back to abnormal tonsils. Now, this is a patient of mine. The picture on the left, this is a CSF flow study. Maybe a little hard to see with the contrast here, but there's a few things you can see. One of them is you can see this concussive vibration of the brain inside the skull. And what's going on there is that there's low cerebellar tonsils. They're blocking the flow of cerebral spinal fluid, so it can't get out. So consequently, there's hydrocephalus. That's why the gyri of the brain are not very discernible here. It's kind of blurred. And so what's happening is that the heart's trying to pump blood into the brain. And normally when it does, the blood moves all the way down into the capillaries, and pulsatile action causes a movement of the CSF so that the CSF can migrate out of the skull. When the cerebellum is down at the bottom of the foramen magnum, like a cork in a bottle, then the CSF can't get out. So consequently, we see this type of pooling here. And shortly after this scan was done, this woman had a percussive adjustment of the atlas to correct the misalignment. And you can see these two scans were done about 15 minutes apart. And you can already see how quickly the CSF is clearing out, the gyri are more discernible, the concussive vibration is significantly lessened. And in fact, you can actually see how the cerebellar tonsils move back up above the foramen magnum. So this is a very dynamic situation. And I think that a lot of times we have people who are presenting with these things, but it's not really being looked at in the context of there being a persisting misalignment of the craniocervical junction causing mechanical stress on the nervous system. That's better. Okay. This one is a gentleman who was a football player, and Dr. Rosa shared this story with me. He came out of the scanner and he was feeling so terrible. He said, "How long have I got, Doc? Am I going to be here for another 3 months?" He really thought he was going to die. And like the other case we saw, it has the same sort of features. We see the pulsatile concussive action on the brain slapping inside of the skull. And we see this vein just dilated and the pooling of CSF. And then a few minutes later, this other scan was done, and the CSF has obviously drained out. The cerebellar tonsils have moved up. This vein has drained out, and the gyri are more easily seen, meaning that the hydrocephalus had cleared. So we can pretty well say, I think it's reasonable to propose, the most plausible explanation is that a change in the alignment of the atlas and the axis at the craniocervical junction had a direct effect on the CSF flow. So then the question becomes, is this a plausible genesis of ill brain health actually due to faulty plumbing? The craniocervical junction is a potential choke point for craniospinal hydrodynamics and may play a causative or contributory role in the pathogenesis and progression of neurodegenerative diseases such as Alzheimer's, Parkinson's, MS, and ALS, as well as many other neurological conditions. So here's an illustration showing how the cerebellar tonsils can migrate down below the foramen magnum and get down in there and literally act like a cork. So if we look at it from the perspective of the spinal canal, spinal cord going down the center, and this area around here, the CSF could flow through. However, with low cerebellar tonsils, it's kind of like somebody standing in the doorway blocking the way. And consequently, we see impairment in the flow of CSF. This is a diagrammatic representation suggesting that what's actually happening is the CSF doesn't just flow straight down. It sort of moves up and down and gradually, slowly moves down. What's happening is that the blood flows into the brain and it creates a positive pressure. Because the skull is a constant volume, that pressure moves the CSF, just a hydrostatic pressure transfer like a hoist in a mechanic shop. But if the CSF can't get out, then the blood pressure will push, but it's not pushing the CSF out. So consequently, what happens is in a normal system, the heart pulses and the blood flows in, so that on systole, it pushes CSF down. On diastole, as the heart's refilling, the pressure backs up just for a second, and it pulls the CSF up a little bit and then back down. So it's moving up a little bit and then down some more, and up a little bit and down some more. So this is a normal CSF flow map. And what this shows is that the CSF, this is during diastole, it's being sucked back up into the brain, and then on systole, it's being pushed back down. But when there's an obstruction in abnormal CSF flow, these pressures increase significantly because of the problem with the flow not being able to be maintained. And this is where we see that percussive action in the CSF flow study, where the brain's being bashed around because there's so much force with the heart trying to get blood into the brain. Now, earlier we had some speakers talking about anxiety and people who have autonomic nervous system imbalance. One of the things to think about is that if the flow of blood into the brain is being impaired because the flow of CSF out of the brain is being impaired, then it makes sense that the brain, trying to protect itself, would cause a persisting secretion of adrenaline to increase the heart rate and increase the breathing to try to compensate for the lack of perfusion. So if a person's sitting in a chair doing nothing, but they feel like they're being chased by a tiger, they'd probably describe it as anxiety. I just wanted to show you a few of these casts of what the actual vascular structure looks like in the brain. It's very similar to any other images, but the point is that what we're talking about here, is that the blood flows in and it has to go and move all the way out and then move all the way back in to come out on the venous side. And it's a very, very complex pathway and network for carrying the blood. So if we start to obstruct that, then we're creating an imbalance throughout the system. Now, when I went to school, they talked about the lymphatic system, and the picture on the left would have pretty well described what was known back in those days about the lymphatics. But with the aid of tracers, they've been able to see that there's actually flow into the lymphatic system from the brain. And so they kind of created this new word called the glymphatic system to describe the flow of CSF towards the lymph, where it's actually supporting the glial cells. So I kind of think of the glial cells as being like the Christmas tree and the neurons being the lights. And so we got to keep the tree going, and the CSF provides the nutrition and carries away the waste for the brain's metabolism. So if there's a problem with the glymphatic system, then there's going to be a problem with brain physiology and brain health. Regulation of cerebral spinal fluid flow in neurodegenerative, neurovascular, and neuroinflammatory disease. Cerebral spinal fluid circulation and turnover provides a sink for the elimination of solutes from the brain interstitium, serving an important homeostatic role for the function of the central nervous system. Disruption of normal CSF circulation and turnover is believed to contribute to the development of many diseases, including neurodegenerative conditions such as Alzheimer's, ischemic and traumatic brain injury, and neuroinflammatory conditions such as multiple sclerosis. Picture on the left is a normal brain, and the picture on the right is an Alzheimer's brain. And one of the significant differences in these two samples is that there was evidence of impaired function of the CSF flow in the Alzheimer's case. Early brain enlargement and elevated extraaxial fluid in infants who developed autism spectrum disorder. The images across the top are what we consider to be relatively normal-looking MRI, a decent amount of CSF. But when we look at the one below, there's a lot of CSF. This would be considered hydrocephalus. And so there appears to be some observations that there's an association between these spectrum disorders and hydrocephalus, again, pointing back to the notion that if the CSF can't get out, it's going to build up and it's going to flood the area. This is a case of an individual. This is a very significant plaque, a multiple sclerosis plaque. Just to get an idea of a timeline, October 2015. And this is before my friend Dr. Rosa used his patented procedure called image-guided atlas treatment. And he reduced the misalignment pattern in the craniocervical junction. And in March of 2016, another MRI was taken, and this is the result. Seeing them side by side, we can see a very, very substantial reduction of the plaque. Here's another case where we can see a plaque, and after correction, the plaque cleared. Same person, another glow of the plaque at a different level, and then further down, some plaques in another area, plaque in another area, and again in another area. I'm not saying that a person who gets their atlas adjusted is going to have a complete reversal of multiple sclerosis. But what I am saying is that we have many anecdotal examples of cases where cerebral spinal fluid flow was restored and there were significant changes that were visible on MRI, and that there was a reduction in the size and number of plaques. I want to just show a few cases in my own clinical setting where I don't have an upright MRI, so we're relying on X-ray to take a look at the craniocervical junction and the alignment. This is a 22-year-old who suffered for 2 concussions within a 1-week period. We've had some other speakers today talking about concussions, and they seem to be connected with a lot of people, having morbidity. This patient was unable to continue with school and was having trouble with dizziness and brain fog. The post-adjustment X-rays show substantial reduction of the plane line, and the dizziness and the brain fog resolved. So the picture on the left is the X-ray I took the day she came into the clinic after having 2 concussions. And the red line again is the atlas, tilted high on the left and low on the right, creating a significant mechanical stress on the nervous system. There's an acute lower angle here between the atlas and the neck. And this is where I know my friend was talking earlier about the trapezius muscles and asymmetry in the shoulders and the angles. And this is an example of an adaptation going on of that nature. When we get the plane line down, we start to see a real difference because now the lower angle's cleared out and the plane line's cleared out, so the blood can get in and the CSF can get out. And these were the numbers. The plane line, the angle of the atlas was tilted high on the left, 3.75 degrees, and on the post it was reduced to 0.5 degree. The upper angle, which is between the center of the skull and the atlas, was 4 degrees, and it came down to 2.25. The lower angle between the atlas and the neck was 7.25, and it came down to 2.25. Here's another case of a gentleman who had a water skiing accident that affected his vision. And again, the post-adjustment X-ray shows a significant reduction, and his symptoms went away completely, and he hasn't had any of that problem for over 1.5 years now. So here again is the distortion, and coincidentally, it's another one that's high on the left, and it reduced nicely and cleaned up, and there was a good resolution in that case. We had 3.25 degrees on the plane line, came down to 1.5. The upper angle was 3.25, came down to 1.25, and the lower angle was 4.75, came down to 0.5 degree. That took a lot of long axis distortion off of the spinal cord. So while I don't have a CSF flow study or an MRI to prove it, I believe that by reducing that tension, the CSF was able to get down and lift the cerebellum up like a boat in the water, and it was able to get flowing again. And that's why he was able to see a resolution of his symptoms. So low cerebellar tonsils, I find that they're definitely underreported in MRI exams. And one of the main reasons for this is because the standard definition for a Chiari malformation is to see cerebellar tonsils of, depending on the author, between 3 and 5 millimeters below the foramen magnum. So unless a measurement like that is observed on an MRI, often radiologists won't even comment at all about the cerebellar tonsils. But I go back to the idea of a fat guy standing in the doorway, it's going to get hard to get through the door. And if the cerebellar tonsils are down into the foramen magnum, they can easily obstruct the flow. So often this kind of thing can be happening concurrently with misalignment of craniocervical junction. You could see on those previous x-rays how it literally can be visualized that the spine has got a twist in it, and it's putting a lot of long axis tension on the spinal cord, which is attached inside each vertebra with the denticulate ligaments. So consequently, it's lengthening the spinal cord and it pulls the cerebellum down like a helium balloon on a string. You just pull it down and the thing comes down. So it can obstruct the CSF flow and it may cause hydrocephalus. And we saw some examples of what hydrocephalus looks like on the CSF flow studies. It can also obstruct the cranial blood flow because of the hydrostatic pressure that builds up when the tonsils are corking or blocking the flow of CSF. If the heart can't displace the CSF, it can't get blood into the brain. So when we talk about assessment, an old saying that to see is to know and to not see is to guess. In order to make evidence-informed clinical decisions, we must first have evidence. Our clinical assessment process must uncover the evidence needed to provide effective care. It is imperative that the assessment detects the nature and extent of the patient's injuries, and history dictates the imaging decisions. So we got plenty of tools in the shed. We can take different x-rays from different angles and different perspectives. We've got video fluoroscopy or digital motion x-ray where we can look at movement of the spine. We've got upright and recumbent MRI and lots of other things that can help us to look at it. Brain SPECT scan can allow us to see the perfusion in the brain. And that's just some of the many different tests that are available. So when a person has ongoing problems and the picture just doesn't add up, it makes sense that we've got to identify the nature and extent of the problem and the impairment itself. We hear a lot of talk. I keep people coming to me saying they've been told they have an unstable atlas. And I keep this picture with me. This is a gentleman who fell out of a tree and fractured his atlas, and it was amazing, but the EMS people and the surgeon was able to get him through that, and he remained neurologically intact even after that devastating fracture. But what I really want to do is just look at that area of the atlas and the axis. So here's an example in the DMX of the open mouth lateral bend, and what we're really looking at is the alar ligaments. So the alar ligament attaches from the occiput up here to the tip of the dens, and its purpose is to restrict rotation. So when people turn their head from side to side, it comes to a stop because of the alar ligaments. If the alar ligaments aren't functioning properly, then we'll see an overhang, and this is just a magnified version. You can see this wide increase of the atlantodontal interspace, and the atlas is hanging off. And the reason is because the weight of the head is leaning down and it's just taking the atlas with it, and the alar ligament is failing to hold it back. And so this is going to put direct mechanical stress on the vertebral arteries, and it's also going to put direct stress on the spinal cord, and it could actually be a reason for low cerebellar tonsils. And this is an illustration of what it actually looks like with the alar ligament when there's some disruption. I use the term subfailure because typically there's a grading system for ligament injury where they talk about it in sort of rule of thirds in grade 1, grade 2, grade 3, the more serious it is. But I think the real take-home message is because in a discussion of ligament disorders in general, some of the other speakers were talking about the abnormalities of ligaments and why they sometimes don't behave properly. It means that it may have sort of an equivalent effect. In other words, if there's only a part of the ligament here on an injured, torn normal ligament, and it's only working at some percentage and it's impaired, then that may be very similar at a physiological level to what's happening with a ligament that is failing to constrain mechanically, even though it might not actually be torn, it just might be having too much elastic property to it. If we take a look at the transverse ligament on the DMX earlier, I said how there was a gap. This gap's a little more easy to see, a little easier to see. And what basically is happening is that the transverse ligament is a band that wraps around the dens and attaches to C1 to constrain the movement. And again, with the weight of the head forward, it's sliding off and you can see the gap there. So this is an illustration of what that looks like. And so when there is a laxity there, there tends to be a lot of vibration. And what can happen over time is that the body will have an inflammatory response to that. And that can result in what we could call a tenosynovitis, a granular buildup, sometimes referred to as a pannus. And in the case of a pannus here, we see this protrusion into the spinal canal where it's taking up space, and that would have been because of the long-term effect of atlas instability or transverse ligament laxity and the body's natural effect to reduce the movement. So in this particular case, in addition to having low cerebellar tonsils, this person is getting choked out on the other side with a pannus. So the significance is, in my view, that it's really important to assess people early and get to the bottom of it before the degenerative cascade starts. Earlier on, Dr. Maxwell presented it in that way, and I very much agree. These things often start out with a person becoming symptomatic, and slowly over time, these symptoms magnify, and then it often even accelerates as things sort of pick up speed and the ball rolls down the hill. And then there's Homer, and we'd probably say that there's no obstruction of CSF flow there. That's not the cause of his problem. I want to thank you all. Has anyone got a question for me while I'm here?